Hello everyone, this is Dr. Madhusudan Rao and the program I teach medical students. Well, today I touch briefly on few MCQs from pediatric cardiology. Number one, a 3 weeks old neonate was diagnosed to have truncus arteriosus without pulmonary stenosis. Which one of the following could be his clinical presentation? He's having truncus arteriosus without pulmonary stenosis. This is the point of importance. What could be his clinical presentation? Which of the following could be? A. Less cyanosis and more severe congestive heart failure. More cyanosis and severe congestive heart failure. Less cyanosis and no congestive heart failure. And less cyanosis and mild CHF. Coming to the understanding of truncus arteriosus, it is a common trunk that is opening into both the ventricles with a large ventricular septal defect. Please remember, my dear students, when there is good pulmonary flow, that is, when the blood is being pumped into the pulmonary circulation without pulmonary stenosis. Here the patient with truncus arteriosus is having no pulmonary stenosis. That means there is free flow of blood into the pulmonary circuit. In this particular situation, there won't be any cyanosis and lungs will be overloaded with blood. That will result in congestive heart failure. So less cyanosis and more severe congestive heart failure is the right answer. More cyanosis and severe congestive heart failure, these two things cannot go together. More cyanosis is because of reduced pulmonary flow. Because there is no pulmonary stenosis, it cannot happen. Yes, there cannot be more cyanosis. Less cyanosis and no CHF. When there is less cyanosis, that means there is a free flow into the pulmonary circulation with the overloading of the lungs, and child will have definitely congestive heart failure. This is wrong. Less cyanosis and mild CHF. This is also not correct in this particular scenario. The right answer is A. Yes, this is the picture showing the truncus arteriosus, the common trunk opening into both the ventricles with a large VSD. So, great vessels, embryological areas from the truncus. And the development of the spiral septum, they divide into aorta and pulmonary trunk. Failure of development of the spiral septum, the truncus remains as the common vessel arising from both the ventricles, that is right and left ventricles with a large ventricular septal defect. When there is no pulmonary stenosis, there will be free flow into the pulmonary circulation and child will present with congestive heart failure in the neonatal period. There will not be any cyanosis, rather a mild cyanosis. This is truncus arteriosus. A is the right answer. Coming to the persistent foramen ovale is a common echocardiography finding during infancy and is hemodynamically insignificant. But the presence of any of the following anomalies may result in shunting of blood across the PFO, causing cyanosis. Well, foramen ovale is an important structure in the heart during fetal life. It allows the blood flow from the right atrium to the left atrium. Well, that is, most of the right atrial blood is received by the inferior vena cava and is directly pumped into the left atrium through foramen ovale. This particular structure closes soon after birth. Persistence of foramen ovale allows the blood flow from right atrium to the left atrium only. But in conditions, in which of these conditions, there won't be cyanosis, and there will be persistent foramen ovale. Now coming to each condition, critical pulmonary stenosis. In this, there is rise in the right ventricular pressure, there is rise in the right atrial pressure, and there will be right to left across the foramen ovale, resulting in cyanosis. Okay, so option A will be associated with presence of cyanosis. Tricuspid atresia, that means there is obstruction for the outflow of the right atrium into the right ventricle. So there will be mounting of a pressure in the right atrium that results in the right to left shunt at the atrial level, again resulting in cyanosis. Pulmonary atresia, in the same grounds, there will be rise in the right ventricular pressure, so much to right atrial pressure, then resulting in the right to left shunt at the atrial level through foramen ovale. This also results in cyanosis. So the answer is critical, answer is hypoplastic left heart syndrome. What is the question here? But presence of any of the following anomalies may result in shunting of blood across the PFO, causing cyanosis except. Otherwise, in which of the following conditions there is no cyanosis? We have already explained that critical pulmonary stenosis is associated with cyanosis. Tricuspid atresia is going to be associated with the cyanosis, and so much so is the pulmonary atresia. We are left with hypoplastic left heart syndrome. That is the right answer. In hypoplastic left heart syndrome, mitral and aortic valves are hypoplastic, left to right shunting of the oxygen blood, and so no cyanosis. Right? In rest of the condition, there is right to left shunt of blood resulting in cyanosis. Yeah, that is the explanation. This is what is going to happen in the hypoplastic left ventricle. B is the right answer. You have encountered a 3-year-old girl diagnosed with moderately large ostium secundum. All the following changes include result of hemodynamics in this child, except. Then coming to understand the hemodynamics in large ASD. Okay. There is left to right shunt at the atrial level. That means there is shunting of the blood from the left atrium into the right atrium. Right atrium also receives the systemic venous return, which will be added to the shunt from the right atrium into the from the left atrium into the right atrium. So right atrium will be overloaded. This in turn empties the blood into the right ventricle. So right ventricle also overloaded. So these two chambers undergo dilatation. Right ventricle ejects this blood into pulmonary trunk, and pulmonary trunk undergoes dilatation. Right? And right ventricular ejection occurs at a normal pressure. There is no increased pressure in the pulmonary circulation. So the pulmonary capillaries are not subjected to trauma. So they do not react. So increased pulmonary arterial pressure is uncommon in atrial septal defect. So rest of the changes, enlarged right atrium is common, enlarged left ventricle is common, enlarged right ventricle can also occur, and left ventricle and aorta are normal. So the answer is B. B. Increased pulmonary arterial pressure is wrong. B is the right answer. Here, a 30-year-old mother gives you the history that according to the cardiologist, her 6-year-old girl was having most common type of asymptomatic ASD. Each of the following includes the features of the above entity except. That means here you should know what are the common features of most common asymptomatic ASD. So they are site of the defect at the region of fossa valis. Is it right or wrong? Yes, it is right. Anatomical site commonly is at the site of fossa valis. That is the area where the foramen ovale closes. Size is less than 2 centimeters. Is a commonly associated with asymptomatic ASD. Usually single defect. Abnormal AV walls. They are not associated with the common type of ASD. They are associated with the ostium primum type of ASD with split tricuspid and mitral valves, resulting in higher mitral and tricuspid regurgitations. It occurs in the children with Down syndrome. It's a part of the endocardial cardiac cushion defects. So that is not a common type of ASD. So answer is C is the right answer. An asymptomatic child with ostium secundum ASD was evaluated for pulmonary systemic flow ratios as advised by her cardiologist prior to admission into the school. Her QPQS ratio is 2:1. Which of the following is the best choice of treatment? Or how do you go about this particular patient? Surgical closure in adulthood. Is it right? Cannot be. Wait and watch for spontaneous closure. Does it happen in the large ASD? Does not happen at all. Wrong answer. Infected endocarditis prophylaxis. It is not given for the patients with ASD. Then surgical closure at the earliest. Yes, this should be done in all the patients with ASD. As early as 1 year of age or before going into the school, patients with ASD should undergo surgical correction. D is right answer. All the following components of Holt-Oram syndrome are true except. So atrial septal defect is usually sporadic. Sometimes it is autosomal dominant, not the autosomal recessive. Hypoplastic radii is true. First degree heart block is common in Holt-Oram syndrome. Ostium secundum ASD is the component of Holt-Oram syndrome, but inheritance is autosomal dominant, not autosomal recessive. C is the right answer. Well, thank you very much, and thank you for patient hearing. I will meet you again in the next class with some more MCQs. Until that time, bye-bye and thank you.